Good afternoon, everyone, and welcome to today's episode of TMC EyeTV, Ophthalmic Instructions Without Borders. This is the online learning platform of the Medical City Eye and Vision Institute. My name is Resival Salongkay. I am a vitreoretina specialist and your host for this episode. We have a great session prepared for you today as we listen to my mentors and colleagues in analyzing and exploring the different new methods in diagnosing and managing one of the burning topics that we have in ophthalmology, diabetic retinopathy. But first, let us listen to the vitreoretina section head of TMC EVI and someone who has also graced us in the previous episodes of TMC ITV, Dr. Arnold Salud, to formally open our session.
Good afternoon, everyone. As we continue to navigate the new normal in light of COVID-19, I think it's very much important to keep in mind the other diseases that continue to hound our patients. And one of these is the silent pandemic of diabetes mellitus. Today, I think we celebrate or we hold the 8th episode of EyeTV, and we will tackle one of the most dreaded complications of diabetes, and that is diabetic retinopathy. And our speakers for today will discuss the current guidelines, the emerging trends, as well as the future in the management and diagnosis of diabetic retinopathy. Many questions continue to arise as there are more developments and innovations, and we will attempt to answer all, if not most, of these questions in the next few minutes. I would like to thank Allergan for partnering with us and making this session a reality. And the management of diabetic retinopathy has evolved in the past so many, or maybe a few years or a few decades. And this would have been impossible without the help of our industry partners like Allergan, who continue to work with us in finding ways to make the lives of our patients better. I would also like to welcome our other viewers, especially those coming from the Philippine Society of Diabetes, Endocrinology, and Metabolism, and would like to thank them for graciously accepting the invitation to watch and learn from this session. And lastly, as head of the section of vitreoretina surgery under the Institute of Eye and Vision of the Medical City, I would like to thank our three speakers for today for accepting the invitation to talk about diabetic retinopathy. And I would like to believe these three are among the best in the country today to discuss this topic of diabetic retinopathy. And lastly, I think our topic for today will not only benefit the ophthalmologists, but our colleagues in the endocrinology department as we listen to the lectures and learn how all these can help the quality of life of our patients with diabetes. Thank you, stay safe, and enjoy the show.
Thank you, Dr. Salud. Thank you also to Allergan for partnering with us in making this episode a reality. As I mentioned, this episode is special, not just for me, but for ophthalmology trainees who have learned from the expertise of our speakers today. We are joined today by renowned vitreoretina consultants who teach and mentor residents and fellows not only at the Medical City, but also in other ophthalmology institutions in the country. Without further ado, I now introduce our speakers, Dr. Sherman Valero, Dr. Paula Silva, and Dr. Ricardo Papa. So, our first speaker will brief us on the current Asian consensus on diabetic macular edema treatment, and he is no other than Dr. Sherman Valero. Dr. Valero is a past president of the Philippine Academy of Ophthalmology and the immediate past president of the Vitreoretina Society of the Philippines. He was my fellowship program director when I was a Vitro Retina Fellow at the Eye and Vision Institute of the Medical City, and he currently serves as the research coordinator for the residents and fellows of the institute. Next up will be Dr. Paulo Silva. He will give us an overview of artificial intelligence in ophthalmology and its applications on diabetic retinopathy. Dr. Silva is an active consultant at the Eye and Vision Institute of the Medical City. He is an assistant professor in ophthalmology at the Harvard Medical School and assistant chief of telemedicine at the Joslin Diabetes Center. He is also the section chief of ophthalmic imaging at the Philippine Eye Research Institute and the director of the teleophthalmology program at the Medical City. And finally, we also have Dr. Ricardo Papa, who will discuss diabetic retinopathy in relation to the cataractus eye, which is something we all encounter as ophthalmologists. Dr. Papa is a retina specialist and also an accomplished athlete. He is a lecturer at the Ateneo School of Medicine and Public Health, the ophthalmology residency training officer at Amang Rodriguez Medical Center, and the clinical head of TMCI Instrument Center. Dr. Papa is also currently the vice president of the Vitrio Retina Society of the Philippines. Okay, all right. So let's get started. Should you have any questions, please feel free to write them down in the comment section below or beside your screen. We will tackle them with our speakers one by one towards the end of our episode. Please stay tuned, and I hope that we all learn from this afternoon. Dr. Valero, the floor, or rather the screen, is now yours.
Thank you very much, Resi, for that very kind introduction, and welcome to everyone to the 8th edition of EyeTV. Special shout out to our guests from outside the country, Mabuhay, and welcome to this session. So today I'll be talking about diabetic macular edema management in the Asian population. This is part of the expert panel consensus guidelines that we formulated last year, together with a lot of the experts in the field from the region, namely Dr. Jay Chablani, Dr. Kelvin Wong, some of them will be familiar to you, Adrian Ko, Jemmy Chung, and from the Philippines, Harvey Uy, Jeffrey Lim, and yours truly. So these are my disclosures. All right, so it may not come as a surprise that diabetic retinopathy is actually the most common cause of irreversible blindness in people of the working age, and this is 20 to 65 years old. So you can imagine not only the economic, but societal impact of this disease in the community. And among the diabetic eye diseases, diabetic macular edema is a common cause of visual decline in these patients. The prevalence of DME after 15 years can be seen as 15 to as much as 25% in patients with diabetes. And it goes up to as high as 30% in patients who have more than 20 years of diabetes. It can occur at any stage of diabetic retinopathy, and if left untreated, 20 to 30% will have some moderate visual loss in 3 years. You multiply this with the sheer number of people who have diabetes in the world. As of last count in 2019, 463 million have diabetes, and this is expected to go up to 700 million in 2045. So you can imagine the gravity of this condition in the coming years. Fortunately, in the last several years, a decade or so, as Dr. Salud has said, many agents such as anti-vascular endothelial growth factors or VEGF agents, anti-VEGF agents, and corticosteroids have been introduced as leading treatment options. However, despite the advances in DME research, there's still a lack of comprehensive guidelines, especially in the Asia-Pacific region, on the use of appropriate first-line agents, including identifying responders, sub-responders, and non-responders. Also, the appropriate time to switch treatment modalities, patient profiling to manage possible side effects, and uncommon complications. So this expert consensus guidelines is hopefully aimed at providing comprehensive recommendations in the management of diabetic macular edema, especially here in the Asia-Pacific region. So the design of this study was as follows. An expert panel was gathered from several countries, Singapore, Malaysia, Philippines, India, and Vietnam. We were given a questionnaire which we answered. This ranged from definitions of treatment response to treatment complications and remedies. These were answered anonymously and was submitted online and were compiled, analyzed, and explored. These questionnaire results were then discussed in a face-to-face meeting 2 years ago, and individual opinions were recorded, and a consensus was sought through voting. Now, consensus on any recommendation was achieved when 75% or 9 out of the 12 panelists were in agreement. And after all that, we were able to achieve consensus in 25 recommendations, which formed the basis of this treatment algorithm. Now, before we go into the treatment algorithm, I think it's important for us to define the treatment responses that we are looking at that can determine what we will do for these patients. Now, the target response of any treatment for diabetic macular edema is a vision of 6/6 or 20/20, or a central macular thickness on your OCT of less than 300 microns. Now, an adequate response is defined as vision of 6/12 or 20/40 or better, and central macular thickness of less than 300 microns, or an improvement in central macular thickness of more than 10% after treatment. An inadequate response is defined as a response lower than 20/20 or 6/6, and macular thickness still elevated at more than 300 microns, or a change in serial central macular thickness measurements of less than 10% after 1 to 3 months or doses. Finally, a non-response is defined as a response lower than 6/6 or 20/20 with macular thickness still more than 300 microns, or a change in CMT of less than 10% after 3 consecutive months or doses. I think we have to go onto full screen for this one so that the audience can see. This is basically the meat of my talk today, the treatment recommendation algorithm for diabetic macular edema, which we define as any diabetic macular edema with a central macular thickness of more than 300 microns, or vision anything less than 20/20 or 6/6 on the Snellen visual acuity chart. Now, we identified several treatment options that can be used as first-line treatment depending on the patient characteristics. Of course, there's anti-VEGF, intravitreal steroids like dexamethasone, and other treatments such as laser and pars plana vitrectomy. Now, anti-VEGF can be used as first-line treatment in center involving diabetic macular edema that is symptomatic and persistent. Also in patients who are phakic and less than 60 years old, and in glaucoma patients. Now, you treat these patients monthly as per the indications, and you assess the response 1 month after the 3rd dose. Patients who have an adequate response should continue treatment, and you continue treatment until the diabetic macular edema is stable, which is defined as no change in visual acuity or OCT after 2 consecutive injections. After this, you can consider treat and extend protocol for these patients. We also agreed that in patients who have an adequate response, but still with some minimal fluid in the retina, you can choose to withhold treatment and observe these patients. And of course, when these patients have no worsening or improvement of DME, you can extend the follow-up period and do a defer and extend. Now, for patients with inadequate response, you can choose to switch treatment within the first 3 months to another anti-VEGF, or you can choose to switch to a different class of drugs altogether. Same thing, you wait for DME stability. And for patients who have no response, which is defined as poor vision, 6/6 or worse, and central macular thickness of more than 300 microns, or less than 10% improvement after 3 consecutive treatments, this is your time to switch to a different class of medications such as steroids. Okay. Now, these patients, along with those who have been chosen to have first-line treatment of IV steroids, such as those with high risk for cardiovascular disease, patients with poor compliance, whether it be because of access issues, mobility issues, or during these times when patients are a little bit concerned about going into the hospital, these patients are good candidates for first-line treatment with steroids. patients with persistent DME, severe edema, diabetic macular edema in pseudophakic patients, patients scheduled to undergo cataract surgery anyway, and those patients with a history of vitrectomy are also good candidates for first-line intravitreal steroids. Now, once you treat these patients, you should follow these up at least 6 weeks post-injection for an IOP check and a subsequent follow-up 2 to 3 monthly post-treatment. Of course, it goes without saying that appropriate counseling on the side effect profile of steroids such as IOP, rise, and cataracts should be discussed with these patients before going into treatment. Now, for patients who receive first-line dexamethasone with an inadequate response, you can now shift to anti-VEGF. Of course, this should be done after discussion of possible side effects of anti-VEGF for those with risk for cardiovascular disease. And for those with adequate response, you continue treating these patients every 4 to 6 months with intravitreal dexamethasone until you have stabilization of the macular edema. Of course, you shouldn't forget the other treatment options for these patients, such as laser and pars plana vitrectomy. Laser is still very useful for non-center involved DME, defined by the consensus group as edema outside 100 microns of the center of the foveal center. The center of the fovea, or meeting the ETDRS CSME classification. Now, for patients with tractional macular edema from vitromacular traction, epiretinal membranes, or very taut posterior hyaloids, pars plana vitrectomy is still a very useful option for these patients. And we also advise considering adding steroids at the end of the surgery to make the edema resolve much faster. Now, with any intravitreal injection, there is a concern about glaucoma and IOP rise, more in steroids than anti-VEGF, but I think we will be surprised that there is also a cumulative probability of sustained IOP elevation in anti-VEGF in 3 years at almost 10%. Now, with steroids, intraocular pressure rise is more well known. A rise in IOP of more than 25 millimeters mercury was seen in 20% of injected eyes in one study with a mean follow-up of 16.8 months. Now, IOP lowering medication was required for a third of these eyes, but less than 1% would require filtration surgery. Now, IOP spikes were seen as soon as 1 week in 50% of patients, and also in the second week, 40% of patients. Thankfully, 78% of these patients with pressure rise can be controlled with just one medication. So it's essential to follow these patients up who are at risk for glaucoma and IOP rise at 1 and 2 weeks post-treatment in order to identify the increasing IOP. Now, these are some of the treatment recommendations in IOP rise treated with dexamethasone by the expert panel group. So we divided the patients into 4 groups. Group 1 are patients with normal IOP with no history of IOP issues. Now, these patients can be followed up. Personally, I follow them up at 4 to 6 weeks post-treatment. But if the clinical picture warrants following them up sooner, then you can follow them up at 1 to 2 weeks. If the IOP is seen to be more than 28 millimeters mercury, then you can initiate anti-glaucoma medication. Now, for group 2, these are patients with a history of steroid response or ocular hypertension. You should initiate anti-glaucoma medication prior to and throughout the treatment. You follow them up more closely at 1, 2, and 6 weeks, and as best as possible, avoid IOP spikes. If IOPs are not controlled, you should withhold giving the next dose of intravitreal dexamethasone. And of course, needless to say, you can refer to your glaucoma colleague if you're at a loss on what to do with these patients. Now, group 3 are patients with a history of controlled glaucoma. You should remember this, controlled glaucoma. These patients can be given, if needed, intravitreal dexamethasone, but they should continue anti-glaucoma medication throughout the treatment to, as best as possible, avoid IOP spikes. You follow them up again more closely at 1, 2, and 6 weeks post-treatment for IOP check. And again, if the IOPs are not controlled, you should not give the next dose of intravitreal dexamethasone. And of course, there's the group of patients, group 4, who develop glaucoma or intraocular pressure rise from intravitreal dexamethasone treatment. These patients, you should discontinue giving intravitreal dexamethasone until the IOPs are controlled. You treat with anti-glaucoma medication, but I think it's best to refer to the glaucoma specialist to help you with the management of these patients. Another concern with intravitreal injections, of course, is cataract development, more so for steroids than anti-VEGF, but anti-VEGF has also been associated with cataract development, but an incidence rate lower than steroids. Now, steroids, we all know, can accelerate cataract development as much as 2/3 of phakic patients would develop cataract-related adverse events. But the good news is cataract surgery can reverse the vision loss due to cataracts. And steroid is actually more preferable in treating post-cataract diabetic macular edema because of its anti-inflammatory activity. And for those patients who have diabetic macular edema and undergoing cataract surgery, you know that you can be performed at the same time in the same setting. Some factors that you need to consider before initializing the treatment for patients. The expert panel actually had a consensus that we need to classify DME patients prior to planning their treatment. We have to look at their perfusion status, the vitreomacular interface, the location of the edema, the clinical course of these patients, the distribution of the edema. But what we could not agree on was whether to do fluorescein angiography at presentation or treatment failure. Personally, I only do fluorescein angiography after I don't see the desired effect on patients. I don't do it at presentation. Maybe we can discuss this later on. I know Paolo has a lot of studies on fluorescein angiography on predominantly peripheral lesions. For vitrectomized eyes, you also have to consider what medication to give. For anti-VEGF, there has been some controversy because efficacy was shown to be not well established, probably due to the increased clearance of the molecule. But there also have been studies that showed no significant difference in both the BCVA, the best corrected visual acuity, and central macular thickness between vitrectomized and non-vitrectomized eyes being given anti-VEGF. However, for steroids, specifically intravitreal dexamethasone implant, it has been shown to be effective in treating persistent DME, both in the vitrectomized and non-vitrectomized eyes, with efficacy and safety profile not affected by vitrectomy. So in conclusion, we hope that these consensus guidelines have provided recommendations that can help you in identifying the types of responders for DME treatment modalities, whether they be anti-VEGF, steroids, laser, or parsplane we hope that this can also help you determine the appropriate time to switch when it is required, identify the case where different modalities can be considered and administered as first line, and manage potential complications of intravitreal dexamethasone use, such as intraocular pressure rise and cataract progression. So with that, I'd like to thank you for your attention, and I turn you over to Paolo, who will be discussing a very interesting topic that we hope we'll be seeing in the very near future, artificial intelligence in diabetic retinopathy. So Paolo, the floor is yours. Thank you.
Hello. So good afternoon, everyone. Thank you, Sherman, for that very comprehensive talk. So we'll now be shifting from discussing how retinal diagnostics will change in the future. I'll specifically be discussing the impact of artificial intelligence and deep learning on diabetic retinopathy evaluation. So the worldwide prevalence of diabetes in 2010 was 285 million. By 2040, the number of people with diabetes is estimated to reach over 642 million. The growing epidemic of diabetes will spare no nation. It is a global health problem that will affect all countries, all regions, and the greatest increase will be seen in developing countries. The Western Pacific region alone, which includes the Philippines, is estimated to have 214 million individuals with diabetes, representing 1/3 of the total global diabetes population. So diabetes is a lifelong disease that presently is without a cure. It is characterized by chronic hyperglycemia resulting from the body's inability to use glucose for energy. This leads to multiple complications in multiple organ systems. Retinopathy is the most frequent diabetic microvascular complication. It affects half of the diabetes population at any point in time. Our current management of patients with diabetes has been shaped by major clinical trials. These studies have showed that the risk of diabetic retinopathy blindness and diabetic macular edema can be reduced significantly with appropriate laser treatment, vitrectomy, and systemic control. Optimal medical control of diabetes and its associated conditions combined with appropriate eye care can reduce the risk for severe visual loss by over 96%. However, routine and lifelong eye examinations are critical to achieving these outcomes. So diabetic retinopathy is largely asymptomatic despite the presence of advanced disease. Its presence is identified only with retinal examinations using dilated eye exams or retinal imaging. Hence, all individuals with diabetes need annual eye examinations that allows early diagnosis and timely treatment that reduces the risk for visual loss. However, despite many years of widely available and promulgated guidelines for eye examinations, a large population of patients still do not get the minimum recommended eye examinations annually. Data from the Southeast Asian region and the Philippines have shown that utilization of eye care services, even in urban areas, is staggeringly low, with an estimated 82% not receiving the minimum eye exam. Telehealth programs have the potential to increase access to evidence-based eye care to allow focused patient education and facilitate integration of eye care within comprehensive diabetes care. We have reported on the impact of telemedicine implementations and diabetic retinopathy assessment rates over a 4-year period in a primary care system in the US. All patients with diabetes were tracked for diabetic retinopathy assessments. Baseline rates were compliant to rates following the implementation of a telemedicine program. The area shaded in blue represents the proportion of patients evaluated by ophthalmologists, while the area shaded in red represents the proportion evaluated by telemedicine. Over the 3 years of follow-up, there is a sustained 20% increase in telemedicine evaluations. This resulted in an increase in the number of patients subsequently evaluated by ophthalmologists. From baseline, there was a 5.6-fold increase in diabetic retinopathy assessment rates, with over 80% of the population receiving timely eye examinations at year 3. So we have shown that a telemedicine program for diabetic retinopathy assessment is both feasible and effective for diabetic patients who are otherwise not compliant with recommended eye examinations. It is convenient for patients, increases surveillance rates, reduces the risk for vision loss through early identification and timely treatment. Based on this global need, an estimated 3.5 million eyes will need to be evaluated per day by 2040. To represent this visually, if each retinal photograph were stacked on top of each other, each day would be each stack would be taller than the Eiffel Tower, the Empire State Building, and the Petronas Towers. I've been using this slide for the past 10 years, and this stack has just kept on growing. So with this global need, there's an accompanying growing burden for eye evaluations and image evaluations. Systematic evaluations of all diabetic patients increases cost effectiveness. All images are required rely on standardized retinal image evaluations, and over the next 2 decades, there is a need to address 1.3 billion retinal images annually. However, teleophthalmology is very much amenable to automated image analysis. All images are acquired remotely at the point of care. These digital retinal images are then evaluated in a store and forward manner, with over 60% of the population having no retinopathy. Furthermore, all features in the retina have been well described and defined, making an ideal model for artificial intelligence approaches. Artificial intelligence has conceptually existed since the 1950s, and long before that in our culture, myths, and science fiction stories. The Turing test for machine intelligence uses the threshold of the ability of a machine to trick a human into thinking it is human, much like the fictional Skynet in Terminator movies. This is what has been termed as a general or strong AI, with the cognitive ability to fully process, understand, and react to information across the board in a highly similar fashion to a human being. However, such systems do not exist today due to current technological limitations. Our current capabilities are restricted to a narrow AI, which are systems that perform specific tasks very well, such as business processing or playing chess that is at a level or even better and more effectively than humans. In AI, in healthcare, AI has been usually been applied to image analysis, such as in radiology, dermatology, and diabetic retinopathy evaluation. In healthcare, is this better or more efficient than humans? So the question is, are humans really efficient? This is a CT scan of a lung with suspicious nodules and a gorilla. Yes, a gorilla. So this gorilla isn't really invisible. But will a radiologist miss a gorilla hiding in plain sight? This was the focus of a study wherein 24 board certified radiologists from Boston's Brigham and Women's Hospital and board examiners from the American Board of Radiology participated in. There were shown 5 sets of chest CT scans to identify suspicious lung nodules. Each set had about 250 scans, and in the last set, there was a gorilla shown there inserted in 5 scans. The gorilla was 48 times larger than the average lung nodule. But even then, 83% of radiologists did not see the gorilla. Furthermore, eye tracking revealed that those who missed the gorilla actually looked directly at the location of the gorilla. So this study highlights that even experts operating in their domain of expertise are susceptible to inattentional blindness. So what does this show us? In the setting of diabetic retinopathy screening programs, there is significant variability in the grading of diabetic retinopathy with low overall agreement rates for DR and DME. Although this improves with increasing specializations, with retina specialists having the greatest agreement rates remain imperfect. So the use of deep learning algorithms can potentially address issues of traditional image-based evaluation. Machine learning is a family of computational methods that allow an algorithm to program itself. These systems learn how to perform a task by using training datasets to develop their own model to achieve the desired output. These systems remove the need to specify the rules explicitly. So deep learning is a subset of machine learning wherein multiple layers of analysis are used to construct an artificial neural network. Each layer is composed of multiple neurons that are each dedicated to a particular task. This allows end-to-end training and classification, as well as feature extraction. Current deep learning algorithms are now able to achieve diagnostic accuracy on par with human graders while requiring minimal manual human input. Diabetic retinopathy can now be readily identified with existing deep learning AI algorithms. There are currently two FDA approved algorithms with impressive AUC curves and high sensitivity and specificity for detecting vision threatening disease. However, identifying diabetic retinopathy is the lowest lying fruit for AI algorithms. Estimating if and when diabetic retinopathy will progress is one of the most important and difficult tasks for physicians caring for patients with diabetic retinopathy. All eyes start with no retinopathy. The rates for progression are highly variable and dependent on multiple risk factors. These are typically incorporated into the clinical decision making process, relying on clinician experience and medical knowledge. The use of AI has the potential to go beyond this and identify novel retinal markers that may more accurately stratify the risk for progression. This is where the future of AI lies. So we have always been taught the practice of medicine is an art. It is an art based on science. So an important caveat in AI is the black box effect and explaining it with science. So algorithms may successfully reach the desired outcome without researchers fully understanding the methods and the processes. There is this lack of transparency as well as unrecognized biases in the training data. So understanding the process is critical to ensure that AI systems will achieve the desired outcomes across a range of data inputs. The most commonly used image evaluation and training libraries usually feature a very good quality set of image of a relatively homogeneous population. So these data sets may not mirror the diverse and challenging clinical scenarios wherein AI systems would eventually be deployed and would be likely of greatest value. An opportunity for future applicability of AI lies in the full integration of electronic health records, providing a wealth of additional data for analysis by an AI system. The use of electronic medical records or the EMR and AI algorithms may allow predictive, individualized modeling. The data captured using the EMR can develop individualized models, predict diabetic retinopathy progression, and visual loss, providing real-time decision support that is both patient and clinical context specific. Current AI algorithms are primarily based on the analysis of fundus photograph, since these are established and widely available. However, the addition of information about the anterior segment, the retinal periphery, or three-dimensional analysis of the macula could potentially add important analyzable data about the current state of an eye as well as the risk for future disease and progression. So in summary, there is a global and national need for diabetic eye care. Evidence-based eye care is effective in substantially reducing the risk of visual loss. Eye care delivery through telemedicine, innovations in retinal imaging, and artificial intelligence may help address the increasing burden of diabetes eye care. Innovative technology will allow us to think in ways not previously possible. Automated retinal image analysis and deep learning will potentially change the way images are evaluated. However, paramount to these is maintaining the quality of care and establishing standards to ensure patient safety and outcomes are improved. Thank you.
Thank you, Dr. Valero and Dr. Silva. Again, if you have any questions for our speakers, please don't forget to write them down or type them down in the comment section, and we will address them towards the end of our session. Before we proceed to Dr. Papa for the final lecture for this session, let us first watch a short message from our sponsor, Allergan.
Okay, so good afternoon, everyone. So I've been tasked today to talk about the issues that cataract surgeons are faced with when operating on diabetic patients, and specifically those with diabetic retinopathy. So it's a fairly broad topic, and I feel that some of the issues I will be discussing actually require a lecture all on their own. So hopefully I will have been able to tackle most of these issues with some level of, I will be able to fully cover these issues in the time that has been given to me. So I'd like to thank the organizers for asking me to speak and congratulate them as well for continuously churning out comprehensive and very interesting virtual conferences. Next slide, please. So these are my financial disclosures. Next slide. So diabetes is a chronic disease with increasing prevalence over time. Next, press please. And the global prevalence of diabetes is at about 9%. Press please. In the Philippines, it's at about 7%. Next slide. Press and press. Okay. So 35% of diabetic patients will have some form of retinopathy. And if you extrapolate this number to 2040 with about 640 million people with diabetes, around 225 million people will have diabetic retinopathy. Next slide, please. So diabetes, there's an increasing incidence of diabetic cataract because of the increasing incidence of diabetes. So cataracts have a 3 to 4 times prevalence in patients who are diabetics who are less than 65 years old, and cataracts are twice as prevalent in diabetics who are greater than 65 years old. And the risk factors here will include the duration of the diabetes and poor metabolic control. Next slide. Next slide. So this is the pathophysiology of cataract formation. It's the polyol pathway. And I won't get into much detail for this, but this basically describes how hyperglycemia will eventually lead into cataract formation. Next slide, please. Next slide. Next, please. So the bulk of my lecture will focus on this slide. So here are the issues that cataract surgeons are faced with when performing cataract surgeries on diabetics. So when you do a cataract on a diabetic patient, you are dealing with more than one condition. You are dealing with a cataract, and potentially you have diabetic retinopathy and macular edema. So the first issue is diabetic retinopathy progression after cataract surgery. Next slide, please. So is there progression of your retinopathy after cataract surgery? Well, the main causes of increased progression will be the length of your surgery and the complexity of the surgery. So surgical inexperience and long surgical duration is in fact associated with faster diabetic retinopathy progression post-operatively. So cataract complications will produce more prolonged inflammation post-op. This inflammation can lead to a breakdown in your blood-retina barrier and thus increase the oxidative stress. So in the previous methods of extracting cataracts, which were intracapsular and extracapsular cataract extractions. So these were longer procedures with bigger slots for the cataracts to come out. So they created a lot more inflammation. So diabetic retinopathy tended to progress. Next slide, please. So what about in phacoemulsification? So I'm talking about uncomplicated phacoemulsification surgery. So what do the reports say? So with uncomplicated phacoemulsification surgery, the reports are actually varied. So you will find some studies that show that there is in fact still diabetic retinopathy progression after phacoemulsification surgery, but other studies will show that the progression is actually due to poor glucose control, the long course of your diabetes, and the outcomes of insulin therapy for diabetes. Next slide. So I was able to find two meta-analyses that looked at uncomplicated cataract surgeries, and these both looked at well-designed studies with patients of comparable diabetic retinopathy in both eyes, where one eye received cataract extraction and the non-operated contralateral eye served as a control. So one of my co-speakers here tonight did one of those meta-analyses. So Paolo and his associates looked at 5 prospective case-controlled trials comparing progression of diabetic retinopathy after phacoemulsification. And here they found no increased progression in retinopathy if the surgery is uncomplicated. And the observed progression is actually postulated to be due to the natural course of the disease. However, in 2016, Wang and his associates looked at 7 prospective trials, and here they found that progression was observed in both groups, both the operated and non-operated eye, and the progression rate of diabetic retinopathy in the operated eye was actually higher than that of the non-operated contralateral eye. And they say that even uncomplicated phacoemulsification surgery does induce inflammation and will damage the blood ocular barrier and the natural defense, which is the lens diaphragm, which leads to a redistribution of your intraocular cytokines, accelerates retinal microvascular disease, and accelerate diabetic retinopathy progression. Next slide. Next slide, please. So what about macular edema? So macular edema has 2 components. You can have diabetic macular edema. You can have pseudophakic cystoid macular edema. So let's look at diabetic macular edema first. Next slide. So does diabetic macular edema progress? So there is, in fact, a higher incidence of macular edema after cataract surgery, and it's reported in eyes with pre-existing diabetic retinopathy. So a DRCR network study showed that worsening of the macular edema after surgery in eyes with existing preoperative diabetic macular edema. So the presence of non-centrally involved DME prior to cataract surgery or a history of DME treatment, these may increase the risk of developing centrally involved macular edema up to 16 weeks after cataract extraction. If there was no pre-existing macular edema, then no centrally involved macular edema was recorded. So again, Wang in his meta-analysis showed 4 articles that showed that the incidence of DME in the operated eye of diabetic patients was significantly higher than that of the contralateral control eye. Next slide, please. Shah, in his report, however, showed that there is no evidence of phacoemulsification causing the progression of DME in patients with low risk or absent diabetic retinopathy or in those with controlled retinal disease. So if there is no diabetic retinopathy, no pre-existing macular edema, then the chances for developing macular edema after surgery is low. Also, CSME that is present in diabetic eyes at the time of cataract surgery is unlikely to resolve spontaneously, but CSME arising after the surgery will commonly resolve, particularly if the retinopathy is mild. Next slide, please. So let's look now at pseudophakic cystoid macular edema. So Irvine gas syndrome, or your pseudophakic CME, so it actually increases, the incidence of PCME increases with diabetes. So the incidence increases to 25% in diabetic patients compared to 0.1 to 2% in those without diabetes. And this is because of the increasing level of inflammatory mediators in the vitreous and the aqueous humor of diabetic retinopathy patients. Next slide. So you need to differentiate DME from PCME because the pathogenesis is different and the treatment is different for either condition. So with DME, the chronic hyperglycemia is usually associated with an advanced glycation end products, an activation of your protein kinase C, your polyol, your hexosamine pathways, which lead to the breakdown of cell junctions, pericyte loss, and inflammation. With PCME, there are acute and local inflammatory reactions that lead to the release of your pro-inflammatory cytokines, prostaglandins, proteases, and complement. And the inflammation will lead to subretinal fluid due to the dysfunction of your RPE cells and the acute breakdown of your inner and or outer blood retina barrier. Next slide. Next slide, please. Can we have the next slide? Okay. So to differentiate DME from PCME, you can do your fluorescein angiography, which will show a petaloid pattern that is associated with hyperfluorescence of your optic disc. And if you don't have retinopathy or microaneurysms, then this is PCME. With OCT, you can also differentiate the two. So with DME, you can have higher ONL to INL thickness ratio parafoveally, microaneurysms, hard exudates, mainly ONL cysts, and a disruption of your photoreceptor layer. So with PCME, you have a higher CFT to retinal volume ratio, a thicker ONL, solely INL cysts, the absence of your ERM, and an intact hyperreflective outer retinal band. Next slide, please. Next slide. Okay, thank you. So let's go now to the timing of cataract surgery. Next slide. So when do we operate on cataracts on diabetic patients? So the move now is to actually operate on them early. So you want to tackle the cataracts before the patient develops any diabetic retinopathy or any macular edema, because from the previous slides, we know that if you do have retinopathy or macular edema, then these will tend to progress. So if you have if you don't have diabetic retinopathy or macular edema, then you want to operate right away to prevent the cataract from, before the cataract prevents visualization of the retina. If the patient has moderate NPDR without CSME and a visually significant cataract, no pre-op laser is required, but you need to do close follow-up on the patient because at some point in time, that moderate NPDR can progress into severe or proliferative diabetic retinopathy, and the patient can also develop macular edema. Next slide, please. If the patient now has severe NPDR to early PDR, so you may want to work with your retina specialist on this if you're not that comfortable with dealing with the complications of diabetic retinopathy. You can begin PRP or an anti-VEGF injection. And if the lens opacity precludes the PRP, you may start with your anti-VEGF injection and complete your PRP after the surgery. If the patient has a high-risk PDR with vitreous hemorrhage or tractional retinal detachment, you may opt to do a combined cataract surgery with vitrectomy. For macular edema patients, you want to treat the macular edema preoperatively by giving an intravitreal injection of an anti-VEGF or steroid injection. And for steroid, you may want to opt for using dexamethasone over triamcinolone or fluocinolone because of the lower risk of IOP spikes. Next slide, please. If you have iris neovascularization already, so these patients need prompt treatment with PRP, you can also inject an intravitreal injection of your anti-VEGF agent to regress the iris neovascularization, and then the cataract surgery can be done after the iris neovascularization regresses. If the patient has NVG, then you want to combine the phacoemulsification with trabeculectomy after the iris neovascularization regresses. Next slide. So let's go now to the preoperative management of cataract surgery. Next slide, please. So these, in a nutshell, is what we do when we manage cataracts in diabetic patients. Next slide. So we obviously send the patients for clearance, and you want the assistance of the endocrinologist and the cardiologist to control the blood pressure and to control the blood sugar. Next slide, please. Which begs the question, does the hyperglycemia need to be controlled prior to cataract surgery? So allegedly, hyperglycemia will increase the risk of post-op surgical complications. It will allegedly delay wound healing, increase the risk of infection, increase the risk of severe post-op inflammation, or lead to retinopathy progression. Push once, please. However, there is little evidence to link high blood glucose with any significant risk in any of these complications. Next slide, please. So currently, there are no internationally accepted guidelines that specifically say what type of glucose control is needed for cataract surgery under local anesthesia. So this is only for local. For general anesthesia, it's different. So the joint colleges, meaning the Royal College of Anesthetists and the Royal College of Ophthalmologists, in their 2012 guideline for ophthalmic anesthesia under local anesthesia, for ophthalmic surgery under local anesthesia, they say that there is insufficient evidence to recommend canceling the surgery above a certain high blood glucose concentration, and that clinical judgment should actually prevail. Next slide, please. But what is the optimal concentration of blood glucose before surgery? So again, there are no studies that evaluate the blood glucose concentration above which elective surgery should be delayed. However, you would be remiss if you did not defer or cancel surgery in patients that exhibited symptoms and signs of acute hyperglycemic emergencies like severe dehydration, hyperosmolar ketotic states, or hyperosmolar non-ketotic states. So in these patients, maybe the surgery should be postponed. So the UK guideline recommends that preoperative HbA1c of less than 8.5%, so it's fairly high, so less than 8.5% can be considered as acceptable for surgery. In a survey of Singapore doctors, they treat and defer for a blood glucose concentration above 300 milligrams, and a threshold of 400 milligrams prompts them to cancel surgery. So the ceiling for them is fairly high. Next slide, please. So should perioperative hyperglycemia be controlled? Well, yes, to a point, but rapid correction of blood glucose levels before surgery is not useful for preventing post-op complications, and rapid correction may actually cause post-op progression of retinopathy and maculopathy in patients with moderate to severe NPDR. So the retinopathy progression after rapid correction of blood glucose control appears to be related to the changes of retina blood flow, a decreased oxygen release capacity of your red cells due to lower blood glucose levels, and the production of your hypoxia-inducible factor 1 alpha after insulin therapy damages the blood-retina barrier. Next slide, please. So you want to avoid decreasing the HbA1c greater than 3% within 6 months post-op, because an HbA decrease of about 0.5 to 1% within 1 month will actually lead to an increased risk of worsening retinopathy. So the advice is, if the diabetes duration is greater than 10 years and the HbA1c is greater than 9% for at least 3 years, patients with moderate to severe NPDR should not receive rapid correction. Next slide, please. So in your ophthalmic evaluation, you check the VA. When you check the pupils, you want to check for any RAPD, because any RAPD will mean there is a severe ischemic disease in one eye. And this can happen with severe cases of diabetic retinopathy. Next slide, please. So in your anterior segment evaluation, so the cornea, about 70% will have diabetic keratopathy. So this is more important for vitrectomy when we scrape the epithelium, but this can lead to poor wound healing. And again, when you examine your iris and pupillary area, you want to look for neovascularization, and you want to check for how well the pupil dilates, because the increased prostaglandin levels and the damage to your parasympathetic supply will damage the pupillary sphincters. Next slide, please. So the lens fluctuates in myopia. It can be a presenting sign in diabetes. And the cataracts you will encounter in diabetic patients mostly are age-related or the senile type. You can have the snowflake types, which are seen in the type 1 diabetics. But you can also have PSCs, cortical cataracts, or a mixed type of cataract. Next slide, please. So when you do your posterior evaluation, you want to check for vitreous hemorrhage. You want to check the optic nerve for diabetic papillopathy. You want to check if there is existing edema in the macula. And of course, the peripheral retina, so you can stage your retinopathy better. Next slide, please. So some of the ophthalmic tests, one slide back. So some of the ophthalmic tests that you can ask for include the OCT. One slide back, please. So the OCT, if you're suspecting macular edema, nowadays you can get in an ultra-wide field fundus photo. This is always good to have a baseline of this so that after the cataract surgery, you have something to compare your examinations with. FA, maybe it's not recommended as much. Only when you suspect there's a lot of ischemia in the eye, you can request for this. B-scan ultrasonography, this is in the cases where you have very dense cataract, and this is for prognostication and for management. You and the patient can decide if there is vitreous hemorrhage and if there is tractional retinal detachment. Maybe you want to do a combined vitrectomy with the phacoemulsification. So next slide, please. So some of the pre-operative meds that you can give, so the use of NSAIDs. So as we mentioned earlier, PCME will increase in diabetic patients. So you want to consider the use of NSAIDs for these diabetic patients. 2 reports have examined whether preoperative prophylaxis with NSAIDs decreased the likelihood of developing post-op CME, and both studies suggested that preoperative use of topical NSAIDs may be beneficial in preventing CME. So the dosage is from about 1 day to 3 days post-op to about 3 weeks post-op. Next slide, please. And you may want to make use of using Nepafenac over the other NSAIDs. So Nepafenac is a prodrug that rapidly penetrates the cornea. The advantages of Nepafenac are the enhanced corneal permeability relative to diclofenac. The rate of hydrolysis is greater in the retina and choroid rather than the iris or ciliary body. So the increased absorption, the target activation, and the greater duration of action may lead to improved efficacy in the posterior segment over the other NSAIDs. Next slide, please. So what about prophylaxis of your macular edema in DR patients after cataract surgery? So I'm referring to giving an anti-VEGF as prophylaxis for DME. So there have been anecdotal reports where patients with no signs of DME, they gave anti-VEGF at the conclusion of the surgery as prophylaxis for edema development. Next slide, please. So again, these are for patients without any DME. So the anti-VEGFs tested were ranibizumab and bevacizumab. So a combination of these anti-VEGF plus uncomplicated phacoemulsification surgery prevented macular thickening as measured by the OCT in mild to moderate diabetic retinopathy patients without previous macular involvement. However, studies have shown that the effect does not persist at 3 months. Next slide, please. So in fact, there is actually an ongoing clinical trial that looks at the different timing of anti-VEGF injections and how they affect the CSF thickness. And it's on its phase 3. This study will be estimated to complete in August of 2021, next year. Next slide, please. Let's look now finally at some surgical tips. Next slide. So you want to do a larger capsulorhexis size, and this is to prevent anterior capsular phimosis. To prevent phimosis as well, you want to do meticulous lens epithelial cell cleanup during the surgery. So the capsulorhexis size, you want it to be at least 6 millimeters in size or larger than normal, but smaller than the IOL optic diameter. I think there are IOLs about 7 millimeters in size. So you may have poor pupillary dilatation, so please be ready with your iris hooks or your Malugin rings or other iris expanders. For the IOL itself, you want to make use of large optical diameters, 6 millimeters or larger, because this facilitates diagnosis and treatment of the peripheral retinal pathologies post-op. So hydrophilic acrylic IOLs have a higher chance of opacification post-op, so your PCOs. So hydrophobic acrylic IOLs, so these may be associated with slightly more anterior chamber flare in the early post-op period. However, your PCO will develop less frequently, and this has the lowest propensity for silicone oil adhesion. So it should be the IOL of choice in diabetic patients with anticipated vitreoretinal surgery. Next slide, please. So that is your phimosis. These are your iris expanders. Next slide. So blue light filtering IOLs are actually okay. So they did not cause any chromatic discrimination effects. What about multifocal or accommodative IOLs? So the use is controversial. Your vitreoretinal surgeons will have difficult visualization of the fundus during vitrectomy and post-operative laser. They may also be aggravated reduced contrast sensitivity, especially for those with pre-existing maculopathy. So if you're going to use multifocal IOLs, make sure the patients do not have any maculopathies present. For silicone IOLs, as mentioned, they will tend to develop condensations during PPV. And if you use silicone oil during your surgery, the silicone oil will attach itself to the posterior portion of the lens. So iris cloth IOLs, you want to avoid these. You want to avoid them in patients with an increased risk of neovascularization. Next slide, please. So in summary, managing cataracts on diabetic patients does not end with the cataract surgery alone. So please be mindful of diabetic retinopathy and or macular edema. So the diabetic retinopathy progression occurs in cases which promote occurrence of inflammation like prolonged surgeries, complex surgeries, and your ECCEs and ICCEs. In uncomplicated phacoemulsification surgeries, the progression of diabetic retinopathy remains questionable. DME generally progresses if there is existing edema or existing uncontrolled retinopathy. In cases of mild diabetic retinopathy or absent pre-existing macular edema, there is no progression of the macular edema after uncomplicated phacoemulsification surgery. So there is also a higher incidence of pseudophakic CME after diabetic cataract surgery. Next slide, please. So you want to operate on cataracts early. You want to treat the existing retinopathy and edema accordingly prior to cataract surgery if possible. Use of NSAIDs pre-op, maybe Nepafenac 0.1%. You want to use these to decrease the risk of PCME and be prepared surgically by doing a larger anterior capsular rhexis size, the use of iris expanders, and you want to select your IOL wisely. Next slide. I think that's my last slide. So yeah, this quote, by failing to prepare, you are preparing to fail. So just be ready when you're dealing with diabetic cataracts. And that's my last slide. Thank you very much.
Thank you, Dr. Papa. So we've listened to 3 very good presentations, and this is indeed a topic that's very relevant to not only retina specialists, but also to all ophthalmologists who encounter diabetic patients in their daily practice. So we've seen some questions on the comments section of our platform, and I think we're now ready to answer some of them. So we can if we can please welcome back our speakers, Dr. Valero, Dr. Silva, and Dr. Papa. Can we have our first question, please? Okay. So for our first question, what do you think is the greatest challenge of bringing AI to our medical setting? What are the pros and cons? So I think this is for Dr. Silva. If you...
I mean, so for AI, it's very simple. You need very good IT infrastructure to be able to implement it. It's straightforward. If you have an IT team that can help with database management, you can connect and purchase the AI systems. It's a good model. But before implementing an AI, you need to be able to first determine what your goal is in implementing the AI system. You don't just say, because AI is such a hot topic, I want to put AI in my system. So you want to be able to know why you're doing it and what your goal is. If you think AI will be able to achieve those, then by all means, you can invest the capital outlay, the personnel outlay, so that you can get good outcomes and improve outcomes from AI. But it's very simple. I mean, it's just IT and an algorithm that assesses the severity of retinopathy in images.
Is there any other concerns aside from the cost of the system?
So, in the Philippine setting, the cost of reading images is relatively low. So, in other more developed countries, implementation of an AI algorithm reduces the cost by only about 30%. So, there's a 30% reduction. This is in a developed country where the reimbursement, the cost of reading each image is high. So right now, all the images in the Philippines are red. Okay, so there's most likely no impetus to do AI without increasing imaging. So if we do intend to implement AI, it should be coupled with an increase in imaging done as a whole. Because if you do AI right now, all images are being imaged. So there's why would you want to do it? So if you implement AI, you have to implement it with a program that will increase imaging to reach a broader population. I think that is the more important aspect of AI implementation here in the Philippines.
Right. Thank you, Dr. Silva. Can we have our next question? Okay, so the next question: how can we best stratify retinal screening programs for diabetic patients, especially during the COVID-19 pandemic, wherein there is limited accessibility and altered health seeking behaviors? This is considering that patients high risk for COVID-19, including diabetic patients. Okay.
I think we can give this to Paolo first.
Okay, so the key here is that diabetic retinopathy will still progress even with COVID. So eyes at high risk for progression will continue to progress. So each person is very unique. There are different progression patterns. I mentioned in the slide, people will progress at different rates. So to be able to stratify your risk, your own personal risk, you do need to get in touch with your ophthalmologist or retina specialist so that he can advise you on what or when you should see each other. But there are general risk progressions for different DR severities. Typically, eyes with no or mild retinopathy are seen every year. If there are extenuating circumstances such as COVID, if there is evidence that the retinopathy is not progressing, typically this can extend it to up to 2 years. But eyes with more advanced retinopathy, moderate, severe, PDR, those eyes need to be seen because the risk for progression is present. Especially eyes with macular edema, especially eyes with multiple systemic risk factors for progression. They still need to be seen. And all of us here who are talking here still continue to see our diabetic patients in our own private practices.
Wait, can I add lang? In addition to that, so for some of my patients, I would have them schedule the tests. So if you have a scheduled test, like an ultra wide field fundus image or an OCT to check for macular edema, the test should run okay. There's less people, especially if you're scheduled, and then the patient can just send the images to the doctor to see if they need an actual face-to-face consult. Unfortunately, telemedicine really doesn't work as well here unless the patient will have, their own personal camera to take pictures or images of the retina. But so I guess the next best thing would be to go to a center that has, not so many people, and then send the images to the doctor.
Yeah, so what they've done in the US and what possibly can be implemented here is a virtual retinal imaging clinic. So, because ultra wide field images and macular scans of the retina can be acquired without dilating the pupils. So, this will minimize the time it takes to image the patient and the time patients stay in the hospital. So, by getting those images done and having those images sent to your retina doctor or your ophthalmologist, you can be able to see if you need, injections, lasers, or if you're safe to follow up in a year or so.
I
I
think,
think,
Right.
sorry,
go ahead.
just to
Go
add
ahead.
lang, I think kasi the base of the question is a lot of patients are still terrified of going to the hospitals. Eh. They really don't want to set foot in the hospitals. But other than having an imaging device separate, I don't know how else they can have their eyes screened effectively uh, without actually having an image done.
Yeah, I also want to stress that hospitals that are not COVID referral facilities are relatively safe. I mean, the medical city has a two hospital facility. It provides patients a very safe avenue to receive non COVID care. So, patients who continue to seek care at medical city can be assured that it is safe for them to receive care.
One thing you have to remind your patients as well and our other colleagues is that patients who were being seen prior to COVID and would have an appointment with you, supposedly, you have to remind them to see you and not just ditch their appointments, because this is when problems happen. So I made it a point after going back to clinics or even during the lockdown. I reviewed all the appointment schedules for the patients and then tried to look for the patients who would really need to be seen. Because there are some patients that, based on history and previous findings, you can actually tell them, okay, we can delay the follow up for a bit. But there are some patients that you really need to see. It's had a bad experience that the patient actually developed neovascular glaucoma because they decided not to see their doctor, and then so it developed over the course of the lockdown. So let that be a cautionary tale. Make sure that you review your charts and see and remind the patient. Don't just leave it up to the patients to decide whether they will come in or not. You should be able to have a discussion with them regarding these things.
Right.
Just to add also to that, I'm sure both of all of us have experienced patients that come in with progressed retinopathy or macular edema, and when you ask the patient, "Oh, why didn't you come in?" Well, I thought things are on lockdown. I'm staying home, and I've had patients who came who weren't my patients, but their blurring of vision progressed because their previous doctor still wasn't either going to clinic or the hospital OPD was in fact closed. So yeah, that's the
I,
reality for diabetic retinopathy.
I have a question for both Paolo and Rob. With this pandemic going on, which is, I don't know how, when will it end, no? When it will end. Do you tend to be more aggressive now with treatment, maybe doing a pan-retinal laser photocoagulation for something less than a high-risk characteristic patient, or maybe doing it in severe NPDR or non-high risk, just because you think that you might not be seeing this patient more often?
Okay. Well, for me, yeah. So that's a very good question, Sherman. No? So yes, I will. So I start off with the severe cases. I will do a severe NPDR and start them off with laser already. I also have patients who post vitrectomy patients, post laser patients who will have occasional vitreous hemorrhage. So I give anti VEGFs even before the pandemic. I've been giving anti VEGFs kunyari every 2 months. So now I've been more proactive in giving a prophylactic anti VEGF injection just to prevent rebleeding. During these home quarantine months.
So, Sherman, I typically will not do laser for eyes with moderate NPDR. I'll continue to follow them. So, type 2 patients who have severe NPDR, I would treat them depending on the patient's circumstance. So, patients who already beforehand tell me they'll be having difficulty coming in, especially for injections, I've begun to start using COSOP. So there's some data from Wills that
Yeah.
suggests if you use COSOP, it may extend the interval for injection. So I've been doing that in patients who say that they will not be coming in or will be having difficulty coming in. So somewhat, to extend the data from Wills is from AMD patients, and I've
Yeah.
extrapolated this for DME patients.
What is
In
the
addition,
Paulo? What is the why does COSOP work? What
So,
is
so it has both a carbonic anhydrase inhibitor and a beta blocker. So they decrease aqueous production. So this decreases the turnover of the fluid in the eye. And then the carbonic anhydrase inhibitor, they suspect that it may help with the macular edema as well.
the other thing that I'm also doing more now is actually shifting a little bit more towards intravitreal steroids for patients with diabetic macular edema, just because it's a little bit more convenient for them, especially for those who are a little bit more concerned with following up in the hospital. So that's also one of the considerations I look into now when choosing my first line for diabetic macular edema. All right, Bessie?
Even for non pseudophakic, sir, you do that.
Well, tend to do it more for pseudophakic. For non-pseudophakic, it will be a discussion. If the patient is a little bit older and has some cataracts anyway, and and their desire to stay home is stronger, and they really don't want to leave their house, then that would be part of the discussion. But it's I think more and more people are this is becoming a little bit more acceptable despite the increased risk for cataract.
Right. So I guess it all boils down to a collaboration between the patient, the clinician, and also the healthcare administrators in terms of providing the patients with a safe environment so that they can still access care despite the pandemic. So I think we're ready for our next question. Do we have any other question? Okay. So the next question, would you agree that the current challenge in the Philippines is actually poor access to eye imaging facilities rather than the interpretation of the images?
Yeah, I completely agree with
Yes.
that. So the key there is we need to increase access to images. You need to go to the communities, potentially image patients there. So there are a lot of work that we've been doing. Resi's been working with me to be able to develop cost-effective means to be able to bring imaging to patients that are not getting imaged.
Paolo, what do you think of handheld camera? The imaging devices for mass screening for diabetic
Yeah, so
retinopathy.
handheld devices have gone substantially better over the past 10 years. The imaging devices from 10 years ago are far, far inferior to what we have now. Uh, we're currently evaluating the different currently available handheld imaging devices to be able to provide recommendations to the Department of Health on which device is best suited for our setting.
So yeah, in impoverished areas, kasi it's hard to get a big imaging system there. So you will need those handheld imaging systems, and it may be impractical for a doctor to go around and going to these far flung areas. So if a non-medical person with a handheld device can go to these areas and do the screening and get pictures, send them to a specialist for reading, that would be perfect. And I think VRSP will maybe doing something like this in the future. So
Yeah,
hopefully.
so Rob, so we plan to do that over the next year or so. So just yesterday, our graders in the Philippine Eye Research Institute had been certified by the UK Grading Center, and they're now imager graders. That means they can take photographs and read the photograph. So the key there is that these are non-medical individuals who've been trained to take photograph and evaluate those photographs. So these individuals participate in a year-long QA program wherein they're provided material and tested to be able to provide different aspects of diabetes eye care, and they undergo a quality assurance program. So every month they need to take an exam to ensure that they're still grading up to par to to UK graders. So this is a program that will be implemented soon in Region 3 in the Philippines. We have 4 certified graders that are able to do this. Hopefully,
Nice.
without if the pandemic wasn't here, we would have been imaging already, but unfortunately, it's been delayed a little bit.
Right.
So
So
Dr.
that's
Salangua is working with me here, no? So Resi is
yes. Yeah, so that's all in the pipeline. So eventually, we'll have those programs and services available, even to the far-flung areas of the country. Okay, do we have any other questions? I think we touched on this a little bit earlier. What are the bare minimum requirements for AI setup to operate in terms of machine facilities, etc.? Again, aside from the ones we mentioned earlier, Dr. Silva, are there any? Is there anything else that we need in order to set up an AI facility?
Yeah, so I think one thing that we should look at is research looking for longitudinal data analysis. As I mentioned in the talk, the lowest lying fruit is finding the retinopathy severity. It's very straightforward, very simple. So this is a task a non-medical person can do very good and very well at a low cost. But the most difficult part is identifying who will progress. So that entails years of clinical experience. It entails expert retina specialists. And if an AI can do that, it can help multiply the number of retina specialists. It will help. It can stratify the length of time images are required. So a very low risk patient with very limited risk factors can be imaged more than a year, maybe 2 or 3 years, or even longer. But an eye with more risk factors need to be seen earlier. So I think longitudinal data analysis, predicting progression, what the eye will look like 2 or 3 years from now, is very important.
Right, right. So I actually attended a webinar with Dr. Suber Wang. I think you're also there, Dr. Silva, and he actually said that detecting DR alone is actually not cost efficient, because we have to also look at how long the patient will have before he progresses or before we need to image him again, and that's more cost efficient in the long run. So any other comments or inputs from our speakers? Okay, so I guess we're ready for the next question. What would we need to develop? What would we need to develop a local retinal image database? And with that info, can that be applied to the algorithms available in the market?
So the main thing in the Philippines is we need to comply with all data privacy requirements. We also need to comply with institutional research boards that ensure that the ethics of research is followed. And then for image requirements, so all you need is the image data set that tells you what the retinopathy is in the eye. And we have that. Multiple centers have that. We have that. So long as it can be provided securely in a de-identified fashion, following all the ethics and requirements of research, um, you know, we can do that.
Okay.
The other thing is also the IP. IP. I mean, IP means intellectual property rights that uh, arise after the development. So, when you have these images and you're going to train an algorithm, potentially that algorithm will generate revenue or for that company that has the algorithm and begins to sell it. And then so institutions need to be able to navigate that very tricky space of IP.
Okay. Any other questions from our audience? This one's for Dr. Papa. Isn't it more probable that the operated eye had more progression of DM ret compared to unoperated eye because the poorer VAI, that the one that's operated first, had more damage from DM to start with?
From the studies that they looked at, the when you do studies, the starting point is the same. So the retinopathy levels were more or less the same in either eye. Is that what the question was? So they're saying that the progression was because they started off with poor vision in the first place? Yeah, no. So the studies, the studies that were set up, both eyes had the same level of retinopathy. So there was, in fact, observed progression from that baseline level. Do you remember your study, Pa Paolo?
Yeah, so I was a resident then.
Yeah.
So, residente pa ako. I was a resident then. So, at that time, I was a first year resident. And then
But
I
yeah,
was,
but really the for phacoemulsification, it's varied. Eh. Some will say there's progression, others will say wala.
so I think it depends on if how good your cortical cleanup is, how intact the bag is, how much inflammation there is after surgery, the baseline severity of retinopathy. So in the vast majority, patients who have low or mild retinopathy, and in those cases, I don't think phaco will cause much progression. But eyes with macular edema, more severe, moderate, or more advanced retinopathy, long-standing, poorly controlled diabetes, these eyes are at risk for progression, and those eyes need to be followed. So, Rob, my only thing, your the slides that you put in, they were from 2006 about the HbA1c targets, the A1C targets and stopping early progression. So I think because of the advent of VEGF injections, really right now we can handle any level of progression that happens. Uh, I don't think we should defer cataract surgery because of hemoglobin A1Cs are high because you can't see the retina. That's a harder thing to do. And if you can't visualize the retina, you're left blind. You can't see the risk for progression, everything. So if a visually significant cataract is there, it needs to be taken out.
Because I don't know about if either you or Sherman, have you experienced where you had your patient cleared and then the patient comes back and say, Doc, pinapababa pa yung blood sugar level.
That's
So
happening.
syempre ipit ka na. You can't say, no, let's just continue because you know it doesn't really matter when you do the surgery. So what are your thoughts on that? Do you continue despite
Yeah,
that?
so I think it's educating our colleagues that this does not impact retinopathy as much, and then whatever severity level that arises after the cataract surgery, we are very well equipped to manage it. Our risk for managing all of these, they can be, we have laser, we have injections, all of that can be done.
And again,
Well,
this is only for local, right? It's not
yeah.
if you're doing sedation or general. That's a different thing altogether. But for local, yeah, if there are no signs of distress with the patient, the ceiling is fairly high for the blood sugar level.
Yeah,
Sherman,
and
Well,
then
going back, yeah, sorry.
Yeah,
Go ahead,
so
Rob.
Rob, most of my patients I do under sedation or monitored anesthesia care. Almost all of my cataracts. I find it safer because you can someone's watching the blood sugar, someone's watching the blood pressure. I think it's a safer environment for diabetic patients.
Well, going back to your discussion with the patient in the first place, do you actually send them for a diabetes clearance prior to surgery if you're going to do it under local anesthesia? Because if your ceiling is quite high, then that begs the question: do you even need the clearance? No. For cardiopulmonary, maybe. I rarely do endocrine clearance now for cataract surgery for patients who the HbA1c and the FBS is not extremely high. So I do away with an endocrine clearance. So I then don't get into that trap where, okay, the doctor says lower the sugar, so I can't do anything. When, as you said, the ceiling is quite high. So I really am not that obsessive compulsive about pre-op clearance for sugar. So I don't know about you guys. No. So I tell them, but I don't even send them for clearance most of the time for sugar at least.
Okay. I think we're ready for our next question. Do pre-op steroid drops have any benefit in preventing post-phaco diabetic macular edema? I think Dr. Papa touched on this a little bit earlier regarding the use of Nepafenac.
well, yeah. Well, the Nepafenac was for post-op pseudophakic macular Irvine gas, not for DME. Steroids for there were no studies that I saw. I don't practice giving pre-op steroids to prevent DME. Paolo, what do you think? Ako, I don't. I haven't encountered any. Siguro if ever pa, mas maaning mga anti-VEGF injections, but drops
Pre-op.
not as a pre-op. Yes.
So I don't give, I typically don't give pre-op steroids, but I give pre-op NSAIDs, Nevanac. I give pre-op Nevanac. And then for patients with existing macular edema that I am forced to do injections, I try to, as much as possible, stabilize the macular edema with VEGF injections prior to doing the surgery. And during the surgery, I do an injection also.
I personally don't use either as pre-op medication. For patients with existing diabetic macular edema, I would treat the diabetic macular edema, as Paula has said, to the best of my ability before doing the cataract surgery. But I don't use either steroids or NSAIDs pre-op.
Right. For what cases do you do combined phaco and intravit, Dr. Silva?
So patients with existing macular edema. So there's retinal swelling that's threatening. So basically CSME, the third definition of CSME, when there's a large area of swelling that's threatening the macula, I would inject. For patients with center-involved macular edema, I would try to flatten that as much as I can before I do the cataract surgery.
So I guess it's very important really to examine your patients pre-op. If we can leave everyone with one message for diabetics and cataract surgery, you need to make sure that you did the best in terms of trying to examine the patients pre-op to make sure, to evaluate whether they have diabetic macular edema, whether it's center involved or non-center involved, so that you can give the best possible care for your patient.
With Paolo,
Do
can
you-
I follow up lang on the? So you said earlier for your diabetic patients with macular edema, you treat the macular edema prior to surgery, and then you still give an anti-VEGF
Yeah,
after surgery.
I continue to give.
Yeah, but what if this is assuming you've already flattened it or
Yeah.
hindi ka na flatten fully?
So sometimes sometimes in some cases you really can't flatten the retina, and then the cataracts getting worse. You're getting poor OCT scans, vision's deteriorating. You want to get the cataract out.
And besides, you might be doing the injections on schedule anyway. So you do it, during the time that you're supposed to give the injection, and you do your cataract surgery. So that's just one go.
Yeah, makakatipid pa ng konti yung patient.
Yeah.
Ito, is there a timeline for you guys? When do you do surgery after the injection? 3 days, 4 days, 1 week? Is there
Surgery for
cataract surgery? So let's say the patient has edema, you give an injection. When will you schedule the cataract surgery after the injection? Or it has no bearing?
So I typically will do, if I'm going to do an injection like close to the surgery date, I'll just do it together with the surgery. You don't want to, I don't want to open the eye, and if I do it a day before, some of the anti-VEGF I put in might go out or something. So I typically want to do it at the same time, and I do the injection after all the wounds are closed.
So you try to stabilize the macular edema as much as you can before the cataract surgery. But if you still have an existing macular edema, you probably, and it's already, that's the best you can do. I would probably just do it at the same time, just like what Paolo said.
Okay. Do you routinely request for macular OCTs before operating on a patient's cataract for diabetic patients?
All the time.
Okay.
Me, I look at the patient if there's some clinical signs of diabetic macular edema. I'm more inclined to do a macular OCT, especially if I'm doing patients with active diabetic macular edema.
Yes, same with Sherman for me. If I suspect that there is macular edema present, I will get a baseline macular OCT prior to the cataract surgery.
Okay, do we have any other questions from the audience? Okay, so next, what's your basis when choosing which medication, whether anti-VEGF or steroid, to use next? I guess this is for DMEs.
Yeah.
Uh,
Well, based on the algorithm that I showed, no, I would probably look at the patients that going to be treated. No, there are some patients, and a majority of the patients will still do anti-VEGF, will still do well on anti-VEGF as first line treatment. The question is when to switch and what to switch to. Typically within the first 3 months, some people say 6 months, but in my case I really look at the first 3 months. If there's very little response, then I would probably think about shifting to a different anti-VEGF. Okay. You should see, in my experience, I don't know with Rob and Paulo, no, the most improvement that you will see, especially in central macular thickness, is during the first few injections. If you're not seeing that after the first 1, 2 injections, you should probably start thinking about shifting at least to a different anti-VEGF at first. And then if you're not seeing a good enough response after 3, 4 injections, then maybe you can start considering shifting to a different class of drugs altogether. So yeah, I
If
don't know the opinion.
Sherman, just to add on that, if you started off with aflibercept, would you
Yeah,
still follow the same path?
I would. You mean if I go to another anti-VEGF? Yes, I have no problem shifting from aflibercept to bevacizumab to ranibizumab to bevacizumab. It you have to discuss that with the patient. But for some patients, bevacizumab works best. For some patients, it doesn't work as well as ranibizumab or aflibercept. So in shifting between anti-VEGFs, I have no issues, shifting between them. So it's just a matter of timing. That's what you need to determine.
So what I stressed with my patient, it's not the brand or the
Yeah.
trade name of the medication that you're giving. It's the frequency of the injections.
Yeah.
It's not that you do a more expensive medication and then one and done. So it's not going to be one and done. It's going to be still an average of 8 injections over the course of the year. So patients need to get repeated routine injections as long as they have edema and the vision is affected. So patients with 20/50 or worse vision, its data has shown that aflibercept provides better outcomes. For patients 20/40 or better, I would any medication can possibly give the same outcomes.
So for Paolo, for you, would you continue the same path after 3? Try and switch between drugs, or continue up to about 8?
So if I see that in a vast majority they all get flat. It's the cases that have these residual swelling that even though how much you inject, that residual swelling is not going away. So that's when you want to switch. Because when you give one injection, be Avastin, Lucentis, idea, the first few months you'll see a marked reduction.
Yeah.
And that's been seen in the data. It's that residual edema that's really difficult in some cases. So you can try switching. There's some data on Ozurdex injections, steroids, but that's the difficult part of treating the macular edema. That's recalcitrant to treatment.
I think that's part of the criteria that we were looking at in that consensus guidelines. It's not just an absolute number of the fluid of the central macular thickness. It's also the change in the macular thickness. So if it's less than a certain percent, the 10%, we pegged it at 10% change, then it's probably not working as much as you want. But for a vast majority of patients, I would have to agree with Paolo that you will get a significant reduction in fluid in the first few months. But if in the first few months you don't get this fluid reduction, and it's not just the absolute number, but the rate of reduction, then I would probably consider other treatments.
okay. Do we have any more questions from our viewers? I guess there are no more questions. Were able to address all of them. And again, thank you, Doctors Valero, Silva, and Papa, for answering the questions and for that very extensive discussion. So that's it for today. We certainly learned a lot from our speakers, and I would like to thank them once again, and TMCI TV for making us a part of this Thursday learning habit. Join us again at 5 p.m. on September 24 for the next episode of TMCI TV to discuss one pressing issue that we ophthalmologists encounter frequently nowadays, especially in the advent of online learning and work from home schemes: computer vision syndrome, or more commonly known as digital eye strain. See our event poster for more details, and don't forget to click the thumbs up button, subscribe, and hit the bell icon below to get notified for whenever we release new videos. Thank you again to Allergan for sponsoring this episode. Thank you to our speakers for lending us their time and for sharing their expertise. And thank you, our dear viewers, for your continued support. Before we close this episode, we would like to launch another segment of EyeTV that will be made available to all our patients via our YouTube channel. This special segment is called Kaunting Kaailaman, where we highlight common ophthalmic conditions to make our patients and audience aware of the steps to be taken when they encounter these at home or at work. This endeavor is done with the help of our ophthalmology interns from the Ateneo School of Medicine and Public Health as their small but sustainable contribution to enhancing the basic ophthalmic knowledge of the public. So let us now see their first video. Again, I am Resi Salongkai. We will see you in the next episode of TMC ITV, Ophthalmic Instruction Without Borders. See you. Bye.
Why?
Bye.
Ang kuliti ay isang impeksyon sa talukap ng mata na maaaring maging mapula at masakit. May hahalin tulad ito sa isang tigyawat o pigsa. May dalawang klase ito, external at internal. Nagkakaroon ng kuliti dahil sa pagpasok ng mikrobyo sa talukap na madalas nanggagaling sa mga maduduming bagay na inilalapat sa mata. Ang mga karaniwang sanhi ng kuliti ay ang paghawak sa mata ng marurumiang kamay, ang kadaliang pagpasok ng mikrobyo sa lugar na natanggalan ng pilik mata, ang paggamit ng luma o expired na makeup, at ang hindi pag-alis ng eye makeup bago matulog sa gabi. Ang pinakakaraniwang mikrobyo na nagdudulot ng kuliti ay ang Staphylococcus aureus. Kapag pumasok ang mikrobyo sa gland sa talukap ng mata, susubukan ng katawan na labanan ito. Dahil dito, magkakaroon ng pamamaga, pananakit, at posibleng pagnana sa lugar ng impeksyon. Ang siyang umbok na ito ay ang tinatawag nating kuliti. Ang kuliti ay maaaring mawala ng kusa pagkalipas ng 1 o 2 linggo. Ngunit, para maagapan ito, maaaring maglapat ng warm compress o maligamgam na tuwalya sa apektadong mata. Mainam na magpakonsulta agad sa doktor kapag napansing lumalala ang pamamaga o kapag may panlalabo ng paningin. Kahit na mukhang tigyawat lamang ang kuliti, huwag itong papuputukin o subukang palabasin ang nana. Iwasan muna ang paggamit ng makeup sa mata at contact lens. Huwag ipagamit sa iba ang tuwalyang ginagamit sa mata. Maaari itong makahawa ng ibang tao. Kung kinakailangan, maaaring uminom ng gamot gaya ng ibuprofen o paracetamol upang maibsan ang sakit sa mata. Maghugas ng kamay bago hawakan ang muka at mata. Kung gumagamit ng contact lens, siguraduhing malinis ang kamay sa bawat pagsuot at pagtanggal nito. Bago matulog, maghilamos para tanggalin ang dumi at makeup. Itapon ang luma o expired na makeup. Palitan ng mascara o eyeshadow kada 2 hanggang 3 buwan. Iwasan din ang paggamit ng makeup ng ibang tao.